everybody. Thank you so much for coming out on this blustery Indian summer evening in San Francisco. So I grew up in Pittsburgh, Pennsylvania. I spent my first practically 54 years there, and I moved here about 4.5 years ago for a leadership position. And I've kept my research lab going. I do what's called translational research because I'm a clinician and I'm also an investigator. I move back and forth between the bench and the bedside and try to ask questions that my patients tell me are important. And I'll tell you a story tonight about how that's going with respect to this topic. So I'm not going to talk about this tonight, but I've invented a drug to treat cancer. It's a decoy oligonucleotide targeting a transcription factor, STAT3. And there's a startup company, and I have some shares in the company, and I consult for some startups in Silicon Valley, specifically XCures and Citizen. So the first thing I want to emphasize is that I get to come here tonight and I get to meet you and I get to tell you stories, but it's really about the team. I do none of this by myself. One of the joys of living in San Francisco and not Pittsburgh, Pennsylvania is this is what it looks like in February. So this is, we couldn't have done this in Pittsburgh outside. So my laboratory is located on the Mission Bay campus. I'm in the Diller Cancer Research Building. And the way science works historically is every investigator is their own little CEO. We have our own labs, we get our own grants, we have our own careers. And what I've learned with the move here to UCSF is it's so much better to do this as a team. So in the front row, you'll see me in the middle, and I co-direct the lab with the two men on either side. Patrick Ha to my left, we recruited from Hopkins. He's the head of head and neck surgery. And the gentleman on my right is Dan Johnson. He's a basic scientist. He actually did his postdoctoral fellowship here in San Francisco, met his wife. We worked together collaboratively in Pittsburgh over several decades. And then when I moved here, I invited him to come with me, and it's just been a wonderful journey having a team to talk about ideas and to mentor all of the medical students and the graduate students. We have high school students, we have undergraduates, and residents and fellows who work with us, and it's really a wonderful experience. So I study head and neck cancer, and the reason I study head and neck cancer is I'm an ear, nose, and throat doctor, and that's the cancer that patients get in the upper aerodigestive tract. And head and neck cancer is relatively less common than some of the more frequently reported cancers like breast cancer, prostate cancer, and colon cancer. But there are 60,000 new cases in the US every year, but worldwide it's a really big problem. It's the #1 cause of cancer in India. It's the #2 cause of cancer in France. And in countries where smoking is more endemic and or there are carcinogenic tobacco products that are used by individuals, it is a far more common cancer. When I learned how to be a head and neck surgeon, I was taught that all head and neck cancers were caused by smoking and drinking, which meant that we really blamed the patients for their disease, and very little was known about it, which was really what motivated me to become a scientist. I loved my cancer patients. I felt good that I could master these technical skills and I could cut out their tumors. But when I cut out their tumors, I left them without the ability to communicate because they lost their tongue or they had their larynx removed and they had to communicate through a stoma in their neck. And even with multimodality therapy consisting of surgery, radiation, and chemotherapy, half of the patients still died. And I thought there has to be something better than this. So if I really want to help these people, I have to become a scientist. So that's why I became a scientist. I did this during residency. I was actually an art history major as an undergrad, so I was very ill-prepared, if you will, to become a scientist. And but the point here is that human papillomavirus is now a major cause of head and neck cancer. This wasn't true until recently. We recognized this in the early 2000s. We went back into our archive of specimens when I was in Pittsburgh, and there was no evidence of a human papillomavirus in the 1950s or 60s or 70s. But increasingly, we saw HPV, particularly in cancers in the back of the throat, the tonsil or the base of tongue. And today at UCSF and most places where they look at it, it's about 85% of the cancers that occur in the back of the throat are caused by HPV. The only way to stop this is to vaccinate everybody before they are exposed to the virus. The FDA just increased the age. We're still vaccinating people up to the age of 46, but there's no real evidence that after exposure, the vaccine is very effective. We do vaccinate, but it's by far the most effective previously. I will tell you, I can tell this anecdote because my daughter's not here tonight. She's a second-year medical student here. She blew me off to study for an exam. And when she was 11, I was taking her to get her HPV vaccine, and she had a real needle phobia. And we were negotiating in the car on the way to the pediatrician's office. And she said, why do I have to get this vaccine? And I explained, so you don't get cervical cancer, so you don't get head and neck cancer, et cetera, et cetera. She said, and all these are related to sex. I'm like, right. She says, okay, Mom, I'll make you a deal. If I promise never to have sex, can I skip the vaccines? I'm like, you know what? I really wish I could take you up on that offer, but you're 11, and this is not going to last. So needless to say, I had her vaccinated. So when we talk about cancers of the head and neck, here is a sagittal section, so it's an MRI. And I'm not going to talk today about sinonasal cancers. They are largely caused by exposure to carcinogens in the environment, chemicals, if you will. Oral cavity cancers are almost all HPV negative, linked to smoking. Larynx cancers are almost all linked to smoking. But cancers of the oropharynx and the hypopharynx are now substantially caused by HPV. But what's, I think, really interesting to me about this slide, and the reason I keep it here, is there are very few cancers that are caused by viruses. And Epstein-Barr virus causes nasopharyngeal carcinoma. And this is endemic in southern China. There are thousands and thousands of cases, every week in these large hospitals. And believe it or not, the city with the highest number of cases in the US of nasopharyngeal cancers is San Francisco, because we have a huge population from southern China. But what's interesting biologically to me is the nasopharynx and the oropharynx are really arbitrarily separated. There's no line. When you look in someone's throat, I don't see a distinct barrier between the nasopharynx and the oropharynx. It all runs together. So the idea that this mucosa is uniquely susceptible to viruses, I think, is really interesting. So as I mentioned, this is the major cause historically of most head and neck cancers, particularly cancers of the mouth and cancers of the larynx. We now have some ballot measures, I believe, that are going to ask if we're going to force tobacco companies to put these kinds of pictures on their products. This is obviously a Marlboro package from France. We in America are unable to ask our tobacco companies to do this, and this is a fungating form of head and neck cancer that's broken through this man's jaw and now extends to the neck. But what I learned from my colleagues in France, I was giving a talk at the Curie Institute about a month ago, is that everybody in France has this really cool holder for their cigarette packs, so they don't have to walk around with this disgusting picture of a cancer on their cigarettes. But the other form that I've alluded to is human papillomavirus. And the reason I love this slide is I actually think if you make it to age 100 smoking, you're probably going to be okay. Most of our patients who die of smoking-related illnesses die before they're 100 years old. But the virus is a very different form of a head and neck cancer. These tumors tend to have fewer mutations. They also tend to have a better prognosis. But what I will tell you is we treat them exactly the same. So we give our patients a combination of platinum chemotherapy and radiation, which if any of you in the room has ever had platinum chemotherapy or radiation or knows someone who has, it's really unpleasant. It's unpleasant to receive it, and the lifelong consequences are real with respect to taste and swallowing. And we don't yet know how to differentially treat HPV positive from HPV negative head and neck cancer. And what I alluded to is the incidence. So HPV positive head and neck cancer is really reaching epidemic proportions. 2 years ago, for the first time, the number of HPV positive cancers in men, throat cancers in men, passed the number of HPV positive cervical cancers in women for the first time. And every year we measure this, the incidence goes up and up and up because nobody in their 40s or 50s or 60s has been vaccinated against the human papillomavirus. So this is real. Head and neck cancer killed a lot of people famous in history. You may know the stories of Ulysses Grant dying from a really painful jaw malignancy. Sigmund Freud, pictured here with his ever-present cigar, also died of a malignancy of the oral cavity. Ironically, J. Robert Oppenheimer, here with his pipe, also died of a malignancy of the mouth, as did Babe Ruth, because one of the things I didn't mention that is absolutely clear is it's linked to smokeless tobacco. So chewing tobacco, smokeless tobacco products are clearly linked to oral cancer, and it's actually quite common in baseball communities. San Francisco was one of the first places in the Giants, in particular, banning oral tobacco from the park. But I went to meet with the Giants a couple of years ago when I got here, and secretly they still all chew because it helps them. They feel like it's really important for their performance. But more recently, and maybe what got the most attention actually was Michael Douglas. So Ann Richards died of head and neck cancer. Gwyneth Paltrow's father, Bruce Paltrow, died of head and neck cancer. But Michael Douglas was the first person to publicly say, I have HPV positive head and neck cancer. And he really speaks about this quite frequently. If you ever see him now on stages, you'll notice that he's got radiation changes on his neck, and his skin is somewhat tight and his voice is different. But he really has come out as an advocate for alerting people to the dangers of HPV and head and neck cancer. So the question that I want to really talk about tonight is, can we prevent head and neck cancer? So we've talked about the vaccine, but until we knew about HPV and the vaccine, the only thing that we could tell people was to stop smoking. And stopping smoking works, but it's really, really difficult for patients to stop smoking. I mentioned in India and other countries that chewing betel quid is the most common etiologic agent for these oral cavity malignancies. But frankly, telling rural and impoverished populations throughout the country of India to stop doing this is anathema. It's simply part of the culture, and they won't do it. And it's really difficult to stop people from inhaling airborne pollutions. Any of you have traveled overseas, particularly in cities like Beijing, it's really so noticeable when the air is filled with these environmental carcinogens. And this would be primary prevention. So if you don't do any of these things, as well as vaccination, that would be primary prevention. But one of the things that I want to take advantage of in our research is, if you are cured of your first head and neck cancer, and 50% of patients will be cured of their first head and neck cancer, we know that you will develop a head and neck cancer at the rate of 3 to 6% per year for the rest of your life. So it can arise in the head and neck, it can arise in the esophagus, it can arise in the lung. But when we see a patient with head and neck cancer, we follow them for life, and we examine them every year because we know that we're going to find another cancer in most patients if they live long enough. So this gives us an incredible opportunity to actually intervene. If you cure a person of their first cancer, can we give them something that will prevent recurrence or second primary tumor formation and allow them to live a full and rich life? So we have studied this. The most common agent that has been studied extensively is retinoic acid. These studies took place, as you can see, around 1990. This was a New England Journal of Medicine paper, and it was based on really pretty good evidence from the laboratory. And they gave patients who were cured of their first cancer high-dose retinoic acid, and indeed, they had improved survival, reduced second primary tumor formation, and it worked. But the problem was it was intolerable. Patients wouldn't take it. They had so many toxic side effects. So what they did was they did a second study, and they lowered the dose of the retinoic acid. But as you can see from these overlapping curves, whether we're looking at disease-free survival or second primary tumor formation, there was absolutely no impact when we gave patients a lower dose. So yes, it was well tolerated, but it didn't work. And this really was the death knell for looking at retinoids and retinoic acid in preventing head and neck cancer. So today, there are no agents that are approved by the Food and Drug Administration to give to people at high risk for developing head and neck cancer. So what we do right now is we watch and we wait. Another, I think, crisis from my point of view is there's a childhood genetic disease called Fanconi anemia. Individuals are born with this genetic alteration in all of their cells, so it's a germline mutation, and these children have leukemia. They get bone marrow failure. We've gotten really, really good. Pediatric oncologists have gotten really good at curing their bone marrow failure. So now these children are living into adulthood, and for reasons that nobody understands, they all get head and neck cancer. And so it is the urgent crisis in the community of Fanconi anemia. I'm on the board of the Fanconi Anemia Research Foundation, and we have a virtual tumor board every week. In fact, this week we're talking about a 13-year-old who just had his larynx removed for head and neck cancer. And the question is, what do we do with a 13-year-old who we know is at really high risk of recurring, and we can't give patients with DNA repair defects like these children have, radiation or chemotherapy, so the only treatment right now is surgery. So hopefully the story I'm going to tell you might be applicable for patients with Fanconi anemia. So I mentioned we cut patients' tumors out. That's really common. We also give them radiation. That's the most common treatment worldwide. And these are the entire suite of drugs that have been approved by the FDA since 1956 to treat head and neck cancer. Not very many drugs at all. The drug that's still used by far the most frequently is cisplatin, and that was approved in 1978. Cisplatin has neurotoxicity, both hearing loss and proprioception loss. And 2006 was a banner year. The first molecular targeting agent, cetuximab, which blocks the EGF receptor. It's also approved for use in some colon cancers. And we now have a 14-year, 15-year experience with cetuximab, and it's only effective in about 15 to 20% of patients, and we have no idea how to identify those patients prospectively. 2016 was a banner year for head and neck cancer. Like in many malignancies, we discovered that if we unleash the immune system with these immune checkpoint inhibitors, pembrolizumab and nivolumab, we can help patients with head and neck cancer, and it's now the most commonly prescribed drug to treat patients with head and neck cancer. But similarly to cetuximab, only about 15 or 20% of the patients will respond to these drugs, and right now we have no idea how to identify who will respond to these agents. We used to think that one medicine was going to help all patients with the same disease. Hence, we gave everybody with head and neck cancer cisplatin or cetuximab or one of the immune checkpoint inhibitors. But today, now we understand that the biology of the patient's tumor really can be understood to guide us to give a more appropriate therapy. There was just an article, I think, in the New York Times this week that talked about somebody making a drug for one patient. So the challenge that we have in the world, not just in the US, is the cost efficacy of these approaches. I'll tell you a little bit of a story. We discovered a mutation in head and neck cancer, and patients whose tumors had this mutation were cured with an oral medicine, an EGF receptor tyrosine kinase inhibitor. We gave the patient 2 weeks of the drug. It's never come back. And we thought, this is amazing. Let's test for this mutation in every patient, and we'll give them this drug. Well, two things. The mutation is present in 1% of patients with head and neck cancer, and no insurance company will pay for the testing. So you have to find alternative sources to pay for the testing. And the questions we have to ask as a society is, are we going to test 100 people in order to find that one person who will respond to that drug? And we published that paper in a high-profile journal probably about 5 years ago, and nothing's been done since then. So these are really complicated questions. So this is a quote from Sir William Osler, who was a grandfather, if you will, of internal medicine at Johns Hopkins. And he says, if it were not for the great variability among individuals, medicine might be a science, not an art. But because everybody's different and every tumor is different, it really is an art. So I had the privilege of co-chairing the Cancer Genome Atlas, the TCGA effort, to really crack open the genetic alterations that characterized human head and neck cancer. We published this paper in Nature in 2015, and it's a pretty complicated slide. But the thing that I want to note is by far the most common alterations were mutations in tumor suppressor genes. So genes that put the brakes on cancer had loss of function mutations. There's very little we can do about that. I can't tell you how many patients I've put on studies where I've injected replacement genes into their tumor and it just doesn't work. It's not a durable impact. So if you have a loss of function of a tumor suppressor gene, and the most common one is P53, we don't really quite know what to do about that therapeutically. So what we decided to focus on in our laboratory is something we could take action on. So when we looked at these patients, we found that an oncogene known as PIK3CA was mutated in 1/3 of HPV-negative head and neck tumors and in 56% of HPV-positive head and neck tumors. And there are drugs that are in clinical development that actually target the pathway that's turned on by this oncogene. So we thought, well, this looks like low-hanging fruit. Let's see what we can do. We then went and we looked at the whole landscape, and now it's about 528 patients that we're talking about. And what we found is that overall, it's about 1/3 of patients. By far, the most common mutations are those that are known as canonical. They occur in many, many different kinds of cancers. We know they're bona fide oncogenes. We know we turn on the pathway. But in fully 1/3 of these patients, they had alterations in other sites of the gene, and we did not know their functional significance. I'm not going to show you all the data today because we're just getting that paper ready for publication, but it turns out about 80% of these non-canonical mutations are also gain-of-function mutations. So if we could actually figure out a treatment to give to patients who have this oncogene turned on in their tumor, we might really be able to make a difference. So around the time we were doing all of this mutational study, this paper came out in the New England Journal of Medicine. This is an epidemiological study, so there's no mechanism involved. It's a very large cohort of patients. It's from Harvard. It's from the Nurses' Health Study. And what they discovered is that in this large cohort, if an individual had a colon cancer, and their colon cancer had a PIK3CA mutation, and they happened to be taking aspirin as chemo prevention for colon cancer, because aspirin is fairly well accepted as a preventive agent for colon cancer, they had improved survival, but they had no idea why this might be. We went back and we looked at the epidemiological evidence in head and neck cancer. And there was a very large screening trial called the PLCO Trial. It was sponsored by the National Cancer Institute. It stands for prostate, lung cancer, and colon and ovary. And so they screened a large number of patients, including at Pittsburgh, for these cancers. But of course, if you follow thousands and thousands of people over decades, you find that some of them develop head and neck cancer. So what they basically found was that there was a protective effect. So in these individuals who were taking non-steroidal anti-inflammatory drugs, they had a lower incidence of head and neck cancer in this large cohort compared to patients who were not taking non-steroidal anti-inflammatory drugs. Again, it's epidemiology. It doesn't mean cause and effect, but it's another supporting piece of evidence that there might be something to this story. So I mentioned that I had a laboratory, and in our laboratory over about 15 years, we did a lot of what's called signal transduction. We looked at oncogenes, in this case the epidermal growth factor receptor, and we looked how it was activated, it was overexpressed in head and neck cancer, and we knew a lot about what was going on in these cells, and we knew that the prostaglandin E2 receptor turned on signaling both directly and indirectly through these tyrosine kinase receptors, but they all converged on PIK3CA. They converged on this oncogenic signaling pathway. And we published a lot of papers on this, and we said, maybe this might be the mechanism that could help protect patients from head and neck cancer if we targeted in the context of these particular mutations. So we did a study. I have the privilege of leading what's called a head and neck SPORE. It's a grant from the National Cancer Institute. It stands for Specialized Program of Research Excellence. I've had this for about 20 years now. And one of the requirements in this large grant is that we collect patients' tissue and we collect information about the patient. So I had a pretty big freezer full of patient tissues, and I knew a lot about these patients. I knew what drugs they were taking when they were diagnosed with their head and neck cancer, and I knew what happened to them. But I didn't know their mutations. So what we decided is we'd go back to this cohort, so it's retrospective, and we'd look and see who was taking an NSAID, a non-steroidal anti-inflammatory drug, after their diagnosis of head and neck cancer. And we defined chronic NSAID use for at least 6 months after their diagnosis. And then we looked at this oncogene. We looked at gene amplification, which is another mechanism of turning on the pathway. We looked at the mutations in this gene, and then we looked at human papillomavirus. And at the end of the day, we had 266 cases. And we asked a really, really simple question. If you have this oncogene in your tumor, number one, is your survival worse? The answer is yes, it is worse. This is not surprising. It's been shown in other cancers. And if you have a mutated oncogene, it shouldn't become as a great surprise that survival is impacted in a negative way. But if you will, the Hail Mary question was, if you have this oncogene in your tumor and you happen to be taking aspirin for some completely other reason, because nobody gives aspirin for head and neck cancer, is your survival any different than if you had neither of those variables? And here's the results. So these are a picture of the 2 graduate students who worked on this project. Noah is actually now working here at the Cardiovascular Research Institute as a program manager, and Matt Hedberg is finishing up his pathology residency at the University of Pennsylvania and going into dermatopathology at WashU. But if you look at the curve on the left where the curves essentially overlap, if this gene was stone cold negative, it wasn't mutated, it wasn't amplified, it did not matter whether you took NSAIDs or not. Your survival at 5 years is exactly what we expect. It's about 50%. As I mentioned, the curve over there on the left, if you have mutation or amplification of this oncogene, and you aren't taking NSAIDs, your survival is worse. It goes down to about 25% at 5 years. But if you happen to have mutation amplification and you're taking an NSAID, at about 75%, it was baby aspirin, your survival goes up to almost 80% at 5 years. And this was true for HPV positive patients, and it was true for HPV negative patients. And this is remarkable. The idea that something as safe and cheap as a non-steroidal anti-inflammatory drug could improve survival of a lethal cancer is really satisfying to someone who's spent her life trying to make an impact on a disease that's really devastating for most people. But this wasn't enough. We needed to understand the mechanism. But this is a case where the patients are telling me that something's going on. The patients are saying, hey, something's going on here, figure it out. So we went back into the laboratory, and we used different models in the laboratory, all of which are imperfect. Nothing really recapitulates the human condition. So we took head and neck cancer cells, and we knew that some cell lines had mutations and some cell lines were wild type. We also worked collaboratively with another lab here at UCSF and looked in lung cancer too. Is it just head and neck cancer, or is it true in other malignancies? And we had cell lines that had mutations, cell lines that were wild type. But maybe the most rigorous controls, we took a head and neck cancer cell line that was wild type, and we engineered it. We put a mutation in. And that way we knew that the cell was identical except for the presence or absence of the mutation, which we could turn on with an inducible promoter controlled by an antibiotic called doxycycline. And what we found in all 3 settings, and this is just showing something called apoptosis, which is programmed cell death, so the cells are dying. So when we looked at the mutant head and neck cancer cells or the mutant lung cancer cells or the isogenic model that we engineered, when the cells had a mutation, they were far more likely to die when we treated them with an NSAID. We used aspirin, we used celecoxib, we used indomethacin, we used Selendec. It didn't matter what we used. All of the NSAIDs had the same impact. So this is just cell culture, though. We then asked a really crazy question. What happens in animals? So PDXs are patient-derived xenografts. So what we do now routinely is when you have your tumor resected, here at UCSF, we take a little piece of the tumor and we put it into a mouse. And we try to grow that as a model with the ultimate aim of using it as kind of an avatar to predict what you will respond to. So we have, about 100 of these PDXs growing. So this is from a patient, and we knew we had these PDXs sequenced. So we asked the question, if you treat an animal bearing a human tumor, if you give them a non-steroidal anti-inflammatory drug, does it matter if there's a mutation in this gene? As you can see from the wild type curves, if there was no mutation in the gene, the tumor continued to grow. You can't give a non-steroidal anti-inflammatory drug and stop the tumor from growing. However, if the PDX had a mutation in PIK3CA, number one, by itself, it grew more quickly, and there was an anti-tumor effect. So the red line on the bottom there, the tumor was growth inhibited simply by giving the animal orally a non-steroidal anti-inflammatory drug. And we did this with 6 different PDXs, which was pretty interesting. And back in terms of the pathway, we're trying to figure out which of the proteins in the pathway controlled by non-steroidal anti-inflammatory drugs is the differential protein between these 2 kinds of models. So we looked at mutant PIK3CA cell lines, and we looked at the protein COX-2, so celecoxib is a COX-2 inhibitor, for example, and then we looked at a whole bunch of cell lines that did not have a mutation, and in general, we found that the cells that had mutant PIK3CA had higher levels of COX-2 compared to the cells that were wild type. And then we took our isogenic model, because this is the more rigorous model, and indeed, rather than just looking at apples and oranges, we took the same cells, we turned on the mutation, and when we turned on the mutation, we could turn on signaling through this pathway, so there's a darker line at phospho-AKT that marks that this pathway is turned on, and we also saw induction of expression of the protein COX-2, and that's the darker line at the bottom. Now, another way, I haven't gotten into this, so I mentioned that PIK3CA mutations are relatively common, but we think that the most important thing is the pathway. So the mutations are a way of turning the pathway on. Another way to turn the pathway on is you turn off the brakes. So PTEN is a brake, and PTEN loss is found in about 30% of cancer patients, including head and neck cancer patients. So now we're talking, if you combine PIK3CA mutation turns it on, you get rid of the brakes by losing function of the brakes with PTEN, it now becomes an incredibly common pathway. And indeed, when we knocked out PTEN from our cells, we saw that the pathway was turned on and COX-2 was induced. And so we're exploring this in the context of our planned clinical trials. And this is, again, looking at COX-2, this time at the RNA level rather than the protein level, and indeed in this isogenic model, when we turned on the mutation, we could induce expression of COX-2 mRNA. This is a little bit complicated, but what I really want to emphasize is that we remember the patients are telling me the truth, not my cell lines, not the animals. They are used to understand mechanism. And the patients we were looking at in our cohort, they were tumor-free. We took their tumor out. We cured these patients, and then we watched them. And it was really the patients whose tumor that was either treated with chemoradiation or surgery or combination thereof, they ultimately had different survival rates if they took aspirin or not. And we said, so therefore, there must be something going on with the immune system. It's not all an anti-tumor effect, because these patients are not walking around for years with tumors that we just aren't able to see. So we know that prostaglandin E2 has a very potent impact on the immune system. We also know that prostaglandin E2 is inhibited by treatment with NSAIDs. So we asked the question, if we simply look at levels of prostaglandin E2 secreted into the medium that we grow our cells in, is there any difference in the levels of prostaglandin E2 in cells that have a mutation versus cells that don't? And indeed, and also, can we decrease prostaglandin E2 by treatment with an NSAID. And we found that in the cell lines that either have a mutation or not, indeed there are higher levels if there is a mutation, and we can downregulate the levels of prostaglandin E2, that is, decrease them when we treat here with either selindex or indomethacin. On the lower panel, we're looking now at our engineered model, so it's a little bit more rigorous than just cell lines that have it or not, and we found exactly the same thing, that there's higher levels of prostaglandin E2 being secreted into these cell lines, supernatants, and we can block it by treatment with an NSAID. But maybe the most intriguing finding is when we looked into the blood of the mice. And this was kind of a crazy thing to do. I mean, we put these tumors underneath the skin of these mice. We give them these drugs by mouth. We find a way for them to ingest it. And then we take we measure the tumors, we measure the anti-tumor effect. And at the end of the experiment, we ask the question, is there any evidence that in the circulation of these mice there's something different? So on the y-axis, we're measuring prostaglandin E2. Here is from the plasma. And you can see that all these dots are individual mice, but the levels of prostaglandin E2 in the blood of the mice who had been implanted with a human tumor that didn't have a mutation, it was relatively low. In contrast, in the blood of the mice who had been implanted with a tumor that had a mutation, they had much higher levels of prostaglandin E2 in the circulation. We also, in collaboration with a laboratory at UC San Diego, were able to measure the levels of prostaglandin E2 in the tumor, and indeed, the tumors themselves had higher levels of prostaglandin E2 when they had a PIK3CA mutation compared to wild type. And this is just showing the impact of aspirin in these PDXs. So this is a lot of PDXs that we looked at. And if you look at, so the message is twofold. Number one is treating with an NSAID is going to reduce prostaglandin E2 in the circulation, whether you're wild type or mutant. That's the way the drug works. But you can see that in these PDXs that were mutant for PIK3CA that had much higher levels of prostaglandin E2 and a larger reduction compared to the mice that were wild type. So what we're now working on is our hypothesis that it is the immune system. So we think that PIK3CA mutation will be associated with a more immunosuppressive tumor microenvironment. So to begin to test this hypothesis, we have to go back to animals. And in this case, we had to find an animal that we could put in a head and neck cancer that has a normal immune system. Because when we put human tumors into mice, if the mice have intact immune systems, they'll reject the tumor and the tumors won't grow. So these mice that we put our human tumors in have an immune deficiency. So this is a mouse oral carcinoma cell model that we've worked with. And indeed, when we amplify PIK3CA or we mutate PIK3CA, we see higher levels of COX-2, a protein I talked about earlier. But maybe most relevant from a clinical standpoint is we see higher levels of PD-L1. So PD-L1 is now a biomarker for response to the immune checkpoint inhibitors. So I told you that both the pembrolizumab and the nivolumab, Keytruda, are approved for use in head and neck cancer. They're being given to many, many, many patients. And we believe that if the patient's tumor has a higher level of the target for the drug, that is PD-L1, that they're more likely to respond to the drug. So here we see that if we mutate or amplify, if we turn on this pathway, we can induce PD-L1, which makes us believe that it's possible that in the setting of, so ultimately we want to give this drug to prevent it from ever coming back. But if a patient has a PIK3CA mutant head and neck cancer and they're getting treated with an immune checkpoint inhibitor, there might be some benefit to adding an NSAID to the treatment protocol as evidenced from this data right here. And now we looked at different factors in the immune system, and what we found is that these MOC1 tumors that had mutations of this gene, they have reduced CD8 positive T cells and reduced natural killer cells, and all of this leads us to believe that our hypothesis is correct and that we're on the right track. But at the end of the day, it's not about curing mice with cancer, it's about curing people with cancer. And our models are terribly limited, but we must use them to really sort out these mechanistic hypotheses. So we want to do a couple of different clinical trials. This is the first clinical trial that we are planning to do because we think this will be a really feasible trial. So there's different, you've probably all heard of phase 1, phase 2, phase 3 clinical trials. Well, this is a phase 0 trial. So phase 0 trials were, if you will, publicized by the FDA in 2006. They really are biomarker studies. And the idea of the phase 0 trial is you give patients a drug. You don't expect the drug to have a clinical benefit, but you expect that the drug will teach you something about biological activity. What's its pharmacodynamic activity? And does it make sense to do this study in developing the drug? So we have a long experience of giving patients with head and neck cancer an experimental agent in the time between we diagnose them and take out their tumor. It usually is several weeks between diagnosis and therapy, and so what we are proposing is that when patients come in and they're diagnosed with head and neck cancer, we'll biopsy them, make the diagnosis, we'll get a baseline CT scan to measure the tumor, and we'll randomize them to receive an NSAID or a placebo. In this case, we're thinking we'll probably use celecoxib because that's been proven to be safe in this setting prior to surgery. You know, I'm a surgeon, we get nervous operating on people who bleed. That being said, baby aspirin has now been used in the window setting and other malignancies, so we may decide to switch to baby aspirin because that's by far the most reasonable drug, I think, to use in the population to have this biological activity. But we also are going to randomize to get a placebo or celecoxib. We'll do 2 to 3 weeks later another CT scan to see if the tumor volume's changed. And the main question we want to answer in this trial is what is the impact of a non-steroidal anti-inflammatory drug on the immune system, on the tumor microenvironment in patients whose tumors have an altered PI3 kinase signaling pathway by virtue of mutation or loss of PTEN. So we think this is going to tell us a lot about the immune mechanisms, and this should also be a fairly straightforward study. It certainly won't harm anybody, and I think we're going to learn a lot. But the definitive trial, and one that will be led by my colleague Julie Bauman, who's now chief of HEMONC at the University of Arizona, is the Cadillac Study. So when I give talks like this, someone says, well, why don't you just give aspirin to everybody, you know, after their diagnosis of head and neck cancer? Well, my husband's a cardiologist, and he will remind me that aspirin does have deleterious side effects. And there were some very, very large randomized trials published in the New England Journal about a year ago that showed that indeed in elderly people who did not have an indication to be taking aspirin, there were a significant number of adverse events related to bleeding. So I don't think it would be responsible for me to recommend that everybody with head and neck cancer take a baby aspirin. So what we hope to do, and we'll need about 300 patients, we'll open this at about 5 different institutions across the country. We're going to operate or give them chemoradiation, but have a sample of their tumor, and then we'll randomize them to either get baby aspirin or a placebo that will look exactly the same. Nobody will know who gets what, so we'll eliminate, if you will, the placebo effect. And we're simply going to look at disease recurrence. We know that most patients who recur with head and neck cancer will do so within 2 years. So we think that this will take us about 3 to 5 years to complete, depends on how quickly we enroll. Most clinical trials are supported by drug companies, and you can't not get a drug company to support a trial with aspirin. So we have an application that will be reviewed in a few weeks at the NIH to give us support for this kind of a study. So I'd like to conclude by thanking you for being here tonight, but also to acknowledge that I just get to come and talk to you. This work is done by so many collaborators and members of my laboratory here at UCSF, collaborator in Arizona, and of course my previous colleagues from the University of Pittsburgh. So thank you very much. Yes, the question is, when you think of NSAIDs, some people think immediately of ibuprofen or Aleve, and I keep saying aspirin. That's a really good point. What we found is that in all of our experimental models, there was no difference in using one NSAID or another NSAID. I mean, people have different side effects from different NSAIDs. So in our focus on aspirin, we are doing 2 things. Number one is inexpensive. So it's off patent, it's inexpensive. And number two, it's so well tolerated. So if we're seeing the same biological impact of a baby aspirin as we are of a more expensive or some non-steroidal anti-inflammatory drug that's associated with higher cost or higher toxicity, our preference was to go with aspirin. So I'm using aspirin is an NSAID, so I'm using aspirin and NSAIDs interchangeably, but your point is well taken. In our retrospective study, we really tried to look at, because our patients took a whole bunch of different NSAIDs, but our samples, once we got to individual NSAIDs, the sample sizes were really too small to make any statistical comparison between Aleve or ibuprofen or celecoxib, et cetera. But good point. Yes? That's so great. So the question is, squamous cell carcinoma of the skin, is it similar to or different from squamous cell carcinoma of the head and neck? And one truism is that if you've had an organ transplantation and you're on chronic immunosuppression, you have a much higher incidence of squamous cell carcinoma of the skin. And the answer is nobody's looked at it. So the only studies that have been published from clinical cohorts are in colon cancer, and now we published our study in head and neck cancer. But what's true is PIK3CA is mutated in a very high proportion of squamous cell carcinomas of the skin as well. So there's no reason to think that it would not work, but I have no direct evidence from those models, and I've not, that's a good, I don't, so the problem with these large-scale sequencing efforts, like the Cancer Genome Atlas supported by the NIH, is they had very rigid inclusion criteria. So if you were an organ transplant patient, we didn't sequence your tumor. So most of the time, people who've had organ transplants are excluded from clinical trials because they have other adverse events or susceptibilities, and so they're generally not included on these clinical trials. So I don't know of anyone who has sequenced a cohort, but that's something that we theoretically should be able to do here at UCSF, because we have a very substantial transplant program, and we probably could go back and find those specimens and do it. But the answer is I don't know. Yes, sir. Yeah, good questions. The question is, what does it say about inflammation? If we can agree that the NSAID effect is primarily an anti-inflammatory effect, what does that tell us about tumor biology and how we might use these agents? Well, what I would say is we don't actually know. So your first statement was the right statement. Can we agree that this is about inflammation? I gave this talk at a chemistry conference, or similar talk at a chemistry conference a few months ago, and someone who'd worked on aspirin a lot in the pharmaceutical industry came up to me and said, I think it's platelets. You know, because aspirin also has antiplatelet function. And so we really don't know precisely what the mechanism. We sort of have been focusing on prostaglandin E2 because of its potent impact on the immune system. The role of inflammation in head and neck cancer has been studied extensively, and it clearly has an impact. And what I will tell you is that non-steroidal anti-inflammatory drugs have been incorporated into some therapeutic trials for head and neck cancer, and it never worked, but I would argue that in the past we were treating unselected populations. So the way most cancer trials work is you have to have a certain stage of a disease. Nobody ever looked at your mutational profile, so it's possible that we missed, seeing a signal because there just were no patients in those trials that had these PIK3CA mutations. Yes, ma'am. Not necessarily. So the question is, yeah. So the question is, when do we do the testing on the tumor for the PIK3CA mutations? This is an evolving world, and I would tell you that the ability to have a tumor tested for mutations, or let's call it a mutation profile, the most well-known profile is something called Foundation Medicine, if people have heard of this. It was a spin-out from my colleagues at the Dana-Farber. So it's essentially targeted sequencing of a certain number of genes. Here at UCSF, we do something called the UCSF 500 panel. So let me make sure I say this correctly. Mutation testing of tumors is absolutely not routine. It's rare. It's almost always in the context of a clinical trial or an experimental protocol. And the reason is nobody quite knows what to do with the data once you get it back, and nobody will pay for it in America. So there are a couple institutions that have very well-funded philanthropic programs to do mutational testing on all of their patients. Memorial Sloan Kettering and the Dana-Farber are the two institutions that I know of. And the vast majority of time, the clinician will order mutational testing if it makes a difference in terms of the treatment. So what's very well known, let's take colon cancer for example. If you have a mutation in a gene called HRAS in colon cancer, we know that you will not respond to cetuximab, the EGFR monoclonal antibody. So it is routine for a colon cancer to be tested for HRAS mutation, because that dictates whether the patient is eligible to receive that drug or not. Another well-known cancer is lung cancer. We know that a subset of lung cancers will have EGF receptor mutations, and patients whose tumors have EGF receptor mutations are candidates, should be treated with an EGFR tyrosine kinase inhibitor. Now, we've moved a little bit from just sequencing those genes to now sequencing whole panels of genes with the goal of getting more information. The vast majority of clinicians choose to get the tumor sequenced when the tumor is recurrent or metastatic. If someone is curable, they will get standard of care. And standard of care still today is some combination of chemotherapy, radiation, and surgery. So mutation testing tends to be reserved for those who have recurrent or metastatic tumors. So we have at UCSF, and I think at almost all academic medical centers, something called a molecular tumor board. So most of the time, so we in head and neck, we discuss our patients as a big group every week, multidisciplinary, and we prospectively discuss the patients that we're seeing and what we're going to treat them with. Are they eligible for a clinical trial? And this happens in every different organ site. So there's a breast tumor board, there's a head and neck tumor board, a lung tumor board, et cetera, et cetera. Molecular tumor board is disease agnostic. So if your tumor has been subjected to the UCSF 500 testing, people from all different disciplines will get together once a week and go over what those results are and what do they mean. And it really is a scouring of the literature to try to understand what this means. And as I said, so I just alluded to early on that I have some data showing that these non-canonical PIK3CA mutations are drivers, and they should be viewed the same as having a canonical mutation, but I haven't published that. So if you're a head and neck cancer patient and somewhere in the world you have your tumor resected and you're found today to have one of these mutations, the clinicians are not going to know that those are driver mutations, because I've got to get this peer-reviewed evidence out. So that's part one. Part two? You said you had a second part. Oh, so the question is, the question is, should you, statistically speaking, since the mutation is common, does it make sense? So that's back to what I sort of said at the end. I mean, the pragmatist would say, my goodness, these alterations are so common. We're talking about life or death. We're talking about baby aspirin. Why wait 5 years for the definitive trial to be done? Why not just take aspirin? And I completely understand that point of view. And, you know, quite frankly, if it was one of my family members, I would probably test their tumor. And if I found a mutation, I would probably tell them to do it. That being said, that would be irresponsible of me as an investigator, because we know that when you do prospective, there's so many biases in retrospective cohorts that you really need to do the prospective trial, and there are serious adverse events, you know, particularly in elderly people, from anticoagulation, and taking even a baby aspirin is a form of anticoagulation. Yes, that's a really, really good question. To my knowledge, no. So I'm sorry, I keep forgetting that. So the question is, I alluded to the possibility that a combination of immunotherapy and aspirin may be particularly efficacious in the setting of PIK3CA mutated tumors. So the question is, given that there's a large database from these companies, BMS and Merck, that have, you know, all of their eggs in this basket of immunotherapy, could we mine that database to determine whether or not this is true? Maybe. There's several challenges. Number one is I don't believe they have the mutational status of many of these tumors. So I can tell you for the head and neck cancers, they don't. You know, it was never part of eligibility criteria for any of the trials to have their tumors mutationally profiled. So they may or may not have the mutational status. That being said, if there's a piece of tumor sitting around somewhere, you probably could do the testing. So, but that's one obstacle. The second thing is information on taking NSAIDs is sometimes really challenging to get. We went to the electronic health record. We believed what was in the electronic health record. That may or may not be true. We all know, we go to doctors, they say, hey, are you still taking all these medicines? And sometimes you are and sometimes you aren't. So I think that the challenge is it would still be retrospective data, and I have a feeling it would be quite limited. And the last thing I'll say, and I don't mean this in a cruel way, but in my long, long experience of working with pharmaceutical companies, these are their crown jewels, and the ability for us to get the agent, let alone their data, is really, really difficult. There has to be something in it for them, and we have to be able to find common ground that would allow them to open up. These are not publicly available databases. Oh my goodness, so the question is about electronic medical records and opportunities for data mining. This is like my job at UCSF. I chair the committee that looks at all of the data assets of UCSF. We just spent the entire day discussing this. The answer is absolutely. And I think what I really want to do, we were talking about that just before, is I want to engage all of us, all of you, as partners in this. There's some slippery slopes. So I'm not sure if you, the National Health Service in England got in trouble politically for selling their data to Google. And it turns out it was perfectly legal to do that. They didn't break any laws, but boy, did they lose in the court of public opinion. There was an article not long ago in the New York Times about the University of Chicago doing the same thing. So I think what's really important is that if we remember, the electronic health record is a billing tool. It's a billing tool and it's a communication tool. I don't much focus on billing. The communication is better. You know, having lived in the world when there were paper records and now lived in the world where there's electronic records, I can now read everybody's notes, whereas that used to be almost impossible to do. But we are working really hard to figure out how we take the information in the electronic medical record and how we manage it in a de-identified way to really generate hypotheses and test hypotheses. We have a service here that does this for UCSF trainees and investigators. We have an entire team of if you will, assistants who help folks ask questions and go back into the database. So I wanted to know, if, for example, I wanted to know if I could do this clinical trial here at UCSF. So one question came up is, how many of our patients come already on an NSAID? Because if patients already taking an NSAID, I can't really do the study. I can't randomize them to placebo. And I was able to make that query into our electronic medical record and find out the percentage of patients who come in and are already taking an NSAID. So it's an incredibly valuable resource, and I think that the more energies we put on partnering with you, and I'm going to make a pitch right now. One of the companies that, and full disclosure, I'm trying to help them because I really, really believe in this. So there is a man named Anil Sethi. He invented the Apple Health apps, and his sister died of metastatic breast cancer about 2 years ago. And they have more money than they possibly know what to do with, but no money could actually stop her from dying of metastatic breast cancer. And the single most important problem she had from diagnosis to death is the transportability of her electronic medical records. So she, Stanford and UCSF do not share electronic health records. Surprise! We're even struggling today with the San Francisco General Hospital bringing everybody on board. So the point is that when you as a patient have to take your information and you want to go get consults, and in this case they went all over the world to try to get consults, and the single barrier, most important barrier, was the portability and the interpretability of her data. So what this company is doing, and this is for free for patients, and I'm happy to tell you how to get it. If you call them or you find them and you say, hey, I just got diagnosed with cancer and I want you to put all my data on a card, what they will do is they will get your consent and they contact UCSF, Stanford, wherever the patient has gotten their care, and they collect all the records for them. And more importantly, they put it all in one place and they interpret it. So they'll say stage 4 breast cancer, and then it will link to the picture of the breast cancer. It'll link to the radiologic record. It'll link to the images. It'll link to the pathology. So it'll allow the patient to control their data and to own their data and to get the best care that they need. And it will really, I think, allow us to be better doctors. So we're about to do a pilot study in the head and neck cancer clinic. We're going to survey my colleagues. How do we do it now? We get consults from all over the place. How do we manage the data now? What is our satisfaction like? What are the gaps? And then we're going to have all of the patients over a certain period put all of their data on this card. It's a virtual card, and we're going to see if that actually improves our ability to take care of them. So I think the electronic health record's a complicated, long answer. It's a wonderful thing, but it's not a panacea because it wasn't intended to be that way. Yeah.
What's the name of the company?
A Citizen, CIITIZEN. Okay? Thank you so much.